Professor Hiso, hi, good afternoon.
Hi.
Please carry on. Thank you.
Okay. Hello, everyone. Welcome to first ASPA FLEX2 webinar. And thank you for sharing your time to this webinar. The title of this webinar is Window to the World, Anesthesia for Eye Surgeries in Children. Okay, let me introduce myself before the webinar. My name is Hisu Kim. I'm the lead moderator of this webinar. I'm the chairman and chief of Department of Anesthesia and Pain Medicine, Seoul National University College of Medicine in Korea. I'm ASPA Executive Committee member. And we have another moderator, Dr. Teddy Stratus Favela, and he is another moderator, and he is a resident physician in Department of Paediatric Anesthesia in KK Women's and Children's Hospital in Singapore. And he is visiting consultant of Pediatric Anesthesia Division in Philippine Children's Medical Center. And he is also ASPA Honorary Secretary. We have three distinguished speakers, and each speaker will discuss the specific topic of eye surgeries in children. And each lecture will be 20 minutes, and last session will be Q&A session. And before the webinar, I give some announcement. If you have any question or comments, please send your question or comments via the Q&A session. And any question or comments will be welcomed. Chat and raise hands functions are disabled. Our moderators will highlight your question to the appropriate speaker during panel discussion. Some questions will be answered by text with the appropriate speaker in Q&A section. A certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. Post-webinar survey will be forwarded tomorrow, April 18th at 5 p.m. in Singapore time through email. Please ensure that you have correctly keyed in your full name and email. This video will be recorded, and you can review the video at ASPA homepage, Facebook, or YouTube. Please visit this site, and this program is supported by WFSA. During the webinar, we have poll questions. When poll is launched, you will be prompted to answer the polling questions. You will have 30 seconds to respond and submit your answer. You will share the result soon after we end the poll. After the results are shared, you may close the poll so that you can see the slide share by our speakers. Okay, let's start the first lecture. The first speaker is Jihyun Lee, and she is a clinical associate professor in Department of Anesthesia and Pain Medicine in Seoul National University in Korea. Her interests are pediatric anesthesia, anesthesia for congenital cardiac surgery, anesthesia for neonate and preterm infants, thoracic anesthesia, clinical research, and perioperative medicine. Dr. Lee, please.
Thank you for a kind introduction, Professor Kim. I will start my lecture with this poll question. A 24-month-old female child is waiting for EUA. She has been diagnosed with retinoblastoma and underwent several times of EUA surgery for chemoport insertion. Before arriving at reception area, peripheral venous access were tried 3 times by nurse in day surgery center, but all failed. Now she is showing severe agitation and crying in the reception area. In this situation, how would you manage this patient? We have 30 seconds. Okay. The majority of attendees choose C, volatile induction with face mask. Okay. I will discuss about the answer later in my slide. And I will start the lecture.
Hello, it's an honor for me to give a lecture in ASPA webinar. The topic of my presentation is anesthesia for common pediatric ophthalmic surgery. Here are the contents of this presentation. What I'm going to talk about are the anesthetic considerations for examination under anesthesia, strabismus surgery, and cataract surgery based on textbook, articles, and my experience. The first is examination under anesthesia. Examination under anesthesia is usually done for uncooperative children who may require tonometry, fundoscopy, ultrasound, or electroretinograms. Patients may have congenital ophthalmic disease, ROP, or retinoblastoma. This is the case we saw in poll question. Actually, I think there would be several options we can choose. However, doing additional attempt of peripheral venous success is malpractice, I think, and to use chemoport for IV sedation is also not recommended as additional skin puncture is required. This child may have fear of seeing the needle. Volatile induction with face mask would be helpful for the fast, smooth induction. But based on my experience, most of children have a great fear of putting something on their face, so someone have to forcefully hold the children. Oral medications such as midazolam and chloral hydrate can be used, but oral administration has lower onset of action and is related to children's cooperation. Additionally, oral midazolam is not available in Korea, and chloral hydrate can induce nausea and vomiting. Intranasal route is a non-invasive procedure and generally well tolerated by children, and it has become increasingly widespread. Dexmedetomidine, ketamine, and midazolam can be administered by this route. Examination under anesthesia is usually short procedure and can be done under MEG or general anesthesia. In many cases, spontaneous ventilation with volatile agent is okay, but IV or intranasal sedative drugs can be used. For general anesthesia, flexible LMA is widely used to secure airway, and mostly neuromuscular blockade is not necessary, but muscle relaxation is required in some cases, such as laser treatment. In addition, some surgeons request full muscle relaxation to prevent eyeball movement during procedure. This is a video showing examination under anesthesia under deep sedation in outpatient clinic. As patients has peripheral line, we administered 1.5 milligrams per kilogram of propofol, and ultrasound B scan was done for 10 minutes. However, as previously mentioned, placing IV catheter is painful and scary for children, and require a person who is able to quickly and effectively place an IV catheter. In contrast, intranasal administration is easy, non-invasive, and usually well tolerated by children. Recently, the effectiveness of intranasal medication for pediatric ophthalmic examination have been widely studied. In this study, authors evaluated the success rate of intranasal dexmedetomidine and oral chloral hydrate in children younger than 3 years old. In addition, the quality of eye position, intraocular pressure were also compared. The dose of intranasal dex was 2 micrograms per kilogram. As a result, about 86% of children could successfully finish the ophthalmic exam in dex group, while only 64% in oral chloral hydrate group. In addition, intranasal dex group showed better eye position than oral chloral hydrate group. Oral chloral hydrate group showed higher incidence of vomiting, so authors concluded that intranasal dex 2 micrograms per kilogram provides more successful sedation and better quality of ophthalmic examinations than oral chloral hydrate for small children. In this study, 2 doses of intranasal dex, 3 micrograms per kilogram and 3.5 micrograms per kilogram were compared in children with glaucoma. 60% of children of 3 micrograms group and 77% of 3.5 micrograms group showed adequate sedation level when dexmedetomidine was used alone. When additional intranasal midazolam was added, about 87% of 3 micrograms group and 100% of 3.5 micrograms group showed adequate sedation level. The authors concluded that intranasal dexmedetomidine appears to be safe and effectively used for the follow-up examination of pediatric glaucoma patients. Many children require repeated anesthesia for serial exam under anesthesia. Consistent anesthetic technique is preferable, but there has been concern that multiple anesthesia exposure may be associated with neurodegeneration in developing brain, and this issue is still covered by many researchers. For example, there is an ongoing study about determining whether multiple anesthesia exposure affect cognitive function for retinoblastoma patients. So, overdose of anesthetic should be avoided, and monitoring of hymnotic level would be required in this vulnerable patient. The next is strabismus surgery. Strabismus surgery is most commonly performed pediatric ophthalmic operation. The procedures usually involve significant tension on the extraocular muscles, so deep, stable general anesthesia is generally used. This procedure is highly associated with oculocardiac reflex, postoperative nausea and vomiting, emergence delirium, and postoperative pain. So, detection, prevention, and treatment of these complications are important. Oculocardiac reflex is that the pressure on the globe or traction of the extraocular muscle induce severe bradycardia or asystole. It is mediated through trigeminal afferent pathway and vagal efferent pathway. It can occur during enucleation, vitreoretinal surgeries, or other orbital surgeries, as well as strabismus surgery. When it occurs, an anesthesiologist should request surgeon to release the traction of eye muscle or pressure. Prophylactic use of atropine and glycopyrrolate is helpful to prevent OCR. Strabismus surgery is related with a higher risk of postoperative nausea and vomiting, especially in children. If no antiemetic prophylaxis is given, around 60% of children suffer PONV following strabismus surgery. In first consensus guidelines for management of PONV, the algorithm for children is also well described. First is to find the preoperative, intraoperative, and postoperative risk factors related to PONV. When strabismus surgery is performed in a 5-year-old child, an anesthesia was maintained using sevoflurane for 40 minutes. There are already 4 risk factors suggesting high risk of PONV. So in this case, we have to give 5-HT antagonist and dexamethasone during surgery or consider TIVA. However, We should be cautious when we use dexamethasone in children with hematological malignancy because dexamethasone is related to tumor lysis syndrome, and also use droperidol in children with long QT syndrome. Regarding postoperative pain, strabismus surgery was historically considered non-painful minor surgery, but according to recent study, the incidence of moderate to severe postoperative pain was 47%. Pain control after strabismus surgery can be done using eye drops, NSAIDs, and intravenous paracetamol. Opioid can be used, but controversial in day surgery. Ice pack compression or distraction are known to be helpful to reduce the pain. Ophthalmic regional block is highly effective for eye surgery and has been widely described, but infrequently used in children. It is also effective to prevent oculocardial reflex. There are three techniques: subtenon blocks, intracornal, and extracornal blocks. Although intracornal and extracornal blocks are effective in vitreoretinal surgery and laser treatment, there are risks of globe perforation, retrobulbar hemorrhage, or inadvertent increase in IOP. Subtenon blocks is considered the safest in children with a lower risk of complications. Emergence delirium is an altered state of consciousness which begins emergence from anesthesia and continues through the early recovery period. Risk factors include the use of lethal agent, preschool age, preoperative anxiety, preoperative poor sleep quality, and multiple muscle or bilateral strabismus surgery. Although those children with who exhibit emergence delirium have episodes of short duration, there may be effects that linger beyond the recovery period. Therefore, emergence delirium must be actively treated. The pediatric emergence delirium is assessed using PAED scale. This is a reported case about possible impact of long-term consequences of emergence delirium in children. A healthy, well-behaved 4-year-old boy received strabismus surgery. The anesthesia was induced using sevoflurane, and then peripheral line was placed. And at the end of surgery, fentanyl and ondansetron were administered for control of pain and PONV. After being moved into recovery room, his parents were waiting for him, but he did not recognize them and began to thrash, cry, and scream for his mother. This behavior lasted for 30 minutes and PAED score was very high. At the time, unfortunately, no medication was administered. After discharge, his parents have reported that he has had frequent tantrums since surgery that include screaming and throwing things. And he has had a difficult time in school and has reverted to bedwetting. His parents relate all these behaviors to be new starting immediately after the surgery. So, it is important for anesthesia providers to continue to explore more effective way on prevention of emergence delirium. Several possible strategies have been introduced to prevent emergence delirium in children. First is behavior management techniques to decrease preoperative anxiety. For example, watching cartoons, video goggles, or handheld video games. These three images are from recent interesting study performed in Korea. Children watched a 4-minute virtual reality video showing operating theater and explaining perioperative process using famous character Bororo. These children showed significantly reduced anxiety level. These efforts would help reduce postoperative emergency delirium. Second, the choice of anesthetic technique may affect the incidence of emergency delirium. According to a meta-analysis published in 2014, propofol-based anesthesia could reduce the emergency delirium after surgery in pediatric patients under 15 years of age. Rapid emergence from inhalation anesthetics has been known to be related to emergency delirium. But according to a previous pediatric surgery, gradual safe brain emergence could not reduce the incidence of emergency delirium. Adjunctive medications can be used to prevent emergency delirium. Use of midazolam at the end of surgery can reduce the emergency delirium without delaying recovery. Opioids such as nalbuphine and fentanyl can be used, and personally, I prefer to use intravenous nalbuphine 0.1 microgram per kilogram in recovery room. Based on recent meta-analysis, ketamine administration at the end of surgery can also reduce the emergency delirium after surgery. Recently, dexmedetomidine has been widely used in pediatric anesthesia field, and about 0.3 to 1 micrograms per kilogram of dexmedetomidine administered during anesthesia induction or at the end of surgery can effectively reduce the emergency delirium. But it may delay the time to extubation or time to LMA removal. Magnesium sulfate has been gradually used as an adjunctive for sedation and anesthesia during general anesthesia, but in terms of emergency delirium, there are conflicting results. Lastly, I will talk about the cataracts. Cataracts in children are common, and if untreated, it can lead to blindness. Many children with congenital cataracts have underlying conditions, which may include difficult airway, cardiac lesions, cervical instability, or bronchopulmonary dysplasia in case of preterm infant. And these conditions would increase the risk of anesthesia. Surgery for bilateral congenital cataracts must be performed within the first several weeks of life to allow for normal retinal detachment. Surgical treatment of cataracts includes lens extraction, phacoaspiration, capsulectomy, and intraocular lens implants. Anesthesia for cataract surgery should provide complete echinacea and meticulous control of IOP. Because most of these patients are infants and of concern for positive vitreous pressure, controlled ventilation with muscle relaxant provides optimal operating condition. The PCO2 should not be increased for IOP control. The anesthesiologist should be aware of associated systemic disease. Postoperative anemia has been reported in the full-term infant after cataract surgery. I'd like to finish my presentation. In this time, I've shown you the anesthetic consideration of common pediatric ophthalmic procedures. Although ophthalmic procedure may be relatively simple, but patients' conditions may not be simple. As being described as several keywords, you can see in this slide, there are many factors we have to consider during perioperative care in children undergoing ophthalmic surgery. Thank you for listening.
Okay, thank you for your nice lecture, Dr. Lee. Let's go to the second lecture. Second lecture. The speaker of the second lecture is Dr. Lan Yao. She is anesthesiologist in chief in Peking University International Hospital and also director of the pain medicine of the same hospital in China. She is a visiting research associate in the National Children's Hospital of Japan in Tokyo. And her interests are anesthesia safety in critically ill patient and comfort medical promotion. Dr. Yao, please.
Yeah, hi, Dr. Hiso. And on behalf of Professor Yao, I will be reading her poll questions. Okay, so she has one poll question, and her question is, what are the advantages of inhalation anesthesia in ophthalmologic surgery for premature infants with low body weight? So the options that we have here. So there are three options. Of course, the first one is that the integrated induction maintenance stable hemodynamics, retention of spontaneous breathing, quick recovery, low risk of drug overdose. Then 1 to 2 MAC induction had little effect on heart rate. And of course, the second option is almost the same, highlighting the integrated induction and maintenance. But in here, it mentions that there's a high risk of drug overdose of inhalational. And the 1 to 2 MAC induction had little effect on heart rate. And the last option states that there is a low risk of drug overdose, but 1 to 2 MAC induction seriously affect the heart rate. Okay, so another 10 seconds, and then we will close the poll. I think most of our viewers have keyed in their answers. All right, then we end the poll here. All right, and we share the results. So from here, we can say that majority of our attendees believe that inhalational anesthesia in ophthalmic surgery for premature infants with low body weight has low risk of drug overdose, and 1 to 2 MAC induction has little effect on heart rate. So the answer for this poll on Professor Yao Lan will actually discuss in her lecture. Thank you.
Hello, everyone. I'm Professor Yao from Department of Anesthesiology, Peking University International Hospital, China. Today, I would like to share with you the anesthesia for eye surgery of low-weight premature infants, anesthesia methods for retinopathy surgery of lower ages group. Today, we are going to share with you 4 aspects of anesthesia in low-weight premature babies' eye surgery. Ophthalmologists are also very concerned about this. So let's go into the part 1, retinopathy of prematurity. ROP, which stands for retinopathy of prematurity, is a proliferate retinovascular disease affecting the retina of premature infants. ROP is a man-made disease related to the degree of prematurity, use of supplement of oxygen, apnea, mechanical ventilation, and is mostly happen to infant born 34 weeks or earlier of gestation and or weighing below 1750 grams. The classification of fundus retinopathy is graded from stage 1 to stage 5. Pictures shown on the PowerPoint are provided by ophthalmologists. Stage 1 is the demarcation line, and started from stage 2, there's a ridge. At stage 5, we can see a total retinal detachment. It grows worse fast, so the patient should be treated as soon as possible. This table clearly explains the risk factors of retinopathy of prematurity. The three main factors are: first, prematurity; second, low birth weight; third, the excessive oxygen supplementation. As shown in the chart, the lower the body weight, the worse the situation is. Low body weight. Premature infants have a very high risk of anesthesia during eye surgery. So we want to move into the second part, anesthesia management of premature infants with ROP. So how do anesthesiologists ensure the safety of those low body weight premature babies at high risk? There is the case data. This is a male baby delivered at 29 weeks of gestation with a body weight 1500 gram, UPGAR 7 at birth, and now at 17 weeks after birth, weighing 1600 grams, with a running nose and heart rate of 160 beats per minute and a respiratory rate of 44 beats per minute. There was a history of 10 days of oxygen therapy. A pre-anesthesia evaluation examination found no significant specificity other than hypoglycemia. Fundus lesions develop very rapidly if not operated soon. Surgery for fundus retinopathy of prematurity is recommended within 72 hours after the first diagnosis. From the study of 92-97 cases, we know that with mild cases like cough, asthma, eczema, and preoperative airway complications, patients can still accept the surgery. But if the general condition is very poor, it is recommended to postpone the surgery for 2 weeks. The excellent coordination from children undergoing eye surgery requires absolute immobility of the body and eyes. Before operation, reasonable abstinence from food and drink is required. The use of pacifier and adjustment of operating room temperature is recommended. After Dick's mental meeting was nasal dripped into the children, they will fall asleep and carried into the operating room for vital signs monitoring. Then the inhalation induction with 60% oxygen plus 5% sevoflurane. Wait for the eyelash reflex disappear and eyeball stable. Place the size 1 laryngeal mask. Then the ophthalmologist will take charge of the retrobulbar nerve block. PSV breathing pattern is preferred for ophthalmic surgery of low body weight premature infants because PSV and laryngeal mask lower risk of respiratory complications and post-operative weaning difficulties. Through the auscultation of breath sound and chest undulation, we decide if the parameters are set correctly. As shown on the right side of the PowerPoint, we published our study on pediatric anesthesia. During the operation, we used 2 to 2.5% sevoflurane for anesthesia maintenance, and vital signs of the child were stable. As mentioned before, the patient is experiencing hypoglycemia, so we use 2.5% GNS at 5 ml per kilogram weight per hour. The parameters of respiratory system are recommended here. The operation takes 45 minutes. 5 minutes after the stop of sevoflurane, the child was awake, and his breathing was restored. Although the child can't express it by word, he can trace the doctor's finger to show that he is conscious by now. Fundus views shown on the PowerPoint are provided by the ophthalmologist. Re-examination showed good improvement. First examination and 5 weeks, 6 months, and 18 months after the surgery. In part 3, I want to introduce our series of studies. Ophthalmologists gathered data from 2012 to 2016, 181 cases in total, and 40 of them are patients at stage 4A, 51 of them are at stage 4B, and 90 of them are at stage 5, which is the worst situation, and all the patients were great after the surgery. In the past, there were only studies of the minimum alveolar concentration of sevoflurane for LMA intubation or extubation in children older than 1 year of age, which is shown here. But little studies have suggested that MAC intubation and extubation of LMA in premature babies. Although the anesthesiology profession does not yet have guidelines for the treatment of premature infants with the sole inhalation of sevoflurane, we have developed our safety guidelines. First, correction of premature infant with age below 37 weeks. The LMA was inserted smoothly, and the MAC50 and MAC95 of sevoflurane were 2.55% and 2.81%, both less than or equal to full-term infants. Second, correction of premature infants with age below 37 weeks, the smooth removal of LMA, and MAC50 and MAC95 of sevoflurane were 1.43% and 1.85%. 3. With eyeball center fixation as the logo, the effect is accurate and high safety. There is evidence to support the adjustment of anesthesia depths in children with low body weight. As shown in the chart, the guidelines told us the MAC for 0 to 1 month is 3.3. The MAC for 1 month to 6 months is 3. The MAC for 6 months to 3 years old is 2.8. And the MAC for 3 years old to 12 years old is 2.5. That is to say, elder the child, lower the MAC. But we find out that the MAC for infants below 37 weeks is 2.55, which is closer to the MAC level of 3-year-old to 12-year-old. The conclusion surprised us. There are 3 main advantages of inhalation anesthesia in fundus surgery for premature babies. First, integrated induction and maintenance, stable hemodynamics, retention of spontaneous breathing, and quick recovery. Second, low risk of drug overdose. 3. 1 to 2 MAC induction had little effect on heart rate. Laryngeal mask placement in fundus surgery for premature babies has 3 advantages. First, insertion, pull out of the MLA, little impact of intraocular pressure. Second, simple and fast operation, shorten the time of oxygen deficiency. 3. Less respiratory complications. But there are also disadvantages that you guys should pay attention to. First, there can be difficulty to remove tracheal secretions. 2. Risk of laryngeal spasms under low depths of anesthesia. Talking about ventilation strategy selection, there are 3 different ventilation modes. The feature of IPPV is that you can set the time cycle and pressure limitation, constant suction flows, but is not ideal for pressure reduction. The feature of PCV is that it provides variable flow rate, reduced peak suction pressure. However, we choose PSV, breathing patterns, for ophthalmic surgery of low body weight or premature infants because PSV provides flow support at each suction and stops when the final suction flow is reduced to a certain proportion of peak flow. Then the final part is the comments and suggestions. Because little babies can't express by word yet, so we use reflex to make sure if the conscious of babies are restored. First, the hand and mouth reflex degeneration from the 3rd month of birth. Second, the absorption reflex degeneration from the 5th month. 3. The foraging reflex degeneration from the 6th month. So these 3 have all become the focus of our efforts to improve the safety of low-weight and premature infants during post-operative period. So the standard of premature infants to leave operating room after apnea is: the child is awake. Touching the child's lips shows chasing a finger. Protective reflex recovery. Body movement, self-exhaling laryngeal mask. Stable vital signs. Air intake more than 5 minutes and SaO2 more than 95%. No dyspnea. No 3 pits. To prevent asphyxiation, we suggest that body weight less than 2,500 grams, corrected age less than 50 weeks, NICU observation for 24 hours, because study showed that after general anesthesia, preterm infants with no history of asphyxia corrected for months below 60 weeks can also suffer from asphyxia, and the risk of asphyxia corrected for months below 56 weeks is more than 1%. Before intubation, SpO2 90 to 95%, more than 85 to 89% of preterm infants, which is gestational age over 36 weeks, had a survival rate and reduced the occurrence of intestinal necrosis. but high oxygen inhalation concentration could aggravate ROP. Our study, titled Low Body Weight Predicted Bradycardia and Desaturation in Retinopathy of Prematurity Surgeries, a retrospective cohort study, was published in 2020. This page shows our series of research papers that have been published. Our study, titled Effective Inspired Concentration of Sevoflurane in Preterm Infants, was published on Paediatric Anaesthesia Comparison in 2011. And our study, titled Comparison of Effective Inspired Concentration of Sevoflurane in Preterm Infants with Different Postconceptual Age, was published on Paediatric Anaesthesia in 2011 too. This page shows more published studies. We also participated in writing of several ophthalmology books. The last thing I want to say is that with the perfect cooperation of anesthesiologists, we were able to save the sight of more premature patients, which will change their lives. It's my pleasure to share our works over the year with you in this webinar, and it's great honor. And I want to proudly show you guys the picture of the outpatient hall of our hospital in Beijing, and we welcome you to visit us in the future one day. Thank you.
Thank you, Dr. Yao, your nice lecture. Okay, let's jump to the last speaker. Okay, our last speaker is Dr. Noor Hamid, and she is a pediatric anesthesiologist in Hospital Sultan Bahia in Malaysia. And she is a clinical honoris professor of MMED, Minister of Health in Malaysia. And her interests are pediatric anesthesiology in airway and regional anesthesia, and also simulation and crisis management. Dr. Hafizo, please.
Thank you. Hi, Dr. Hiso. Thanks for the introduction. So my topic today will be related to intraocular pressure. So we start with the few poll question. Question number 1. The following has no or insignificant effect on the intraocular pressure except. This is a single best answer. You have 30 seconds to choose. Okay, so majority has answered pre-medication with oral ketamine. Okay, so we move on to the second question. Second question. Can we move on to the second question? Okay. So this is also a single best answer. The question is, which of the following procedure potentially increase intraocular pressure the most? Supraglottic airway device insertion, supraglottic airway device removal, endotracheal intubation, awake extubation, or deep extubation? You have 30 seconds to answer. Okay, majority answer is endotracheal intubation. Second, the first majority is the awake extubation. So we go on to the third question first. How will you anesthetize this patient? This is a scenario of a 3 years old boy come in with blurry of eye and reduced in vision, coming for examination under anesthesia and IOP measurement. So how would you anesthetize this child? A, GA inhalation induction with sevoflurane. B, intravenous induction with propofol. C, intravenous induction with ketamine. D, monitored sedation with dexmedetomidine. Or E, monitored sedation with ketamine. You have 30 seconds to answer. So from this question, majority would go with inhalation induction with sevoflurane and followed by monitored sedation with dexmedetomidine. All these three questions, I will discuss the answer during my lecture later. Before I begin, I have no financial conflicts to disclose in relation to this presentation. This is Hospital Sultanah Bahia. We have 1,100 beds and we offer 45 subspecialty services. Today I'll be sharing about factors affecting intraocular pressure as well as the operating field. A quick glance on the anatomy. The eye globe is essentially a non-compliant sphere formed by three concentric layers of sclera, choroid and retina. It is protected within a rigid orbit. Therefore, the eye and the orbit mimic the brain and the skull, where any changes in the volume of the eye content within the orbit will change the intraocular pressure. Intraocular pressure is defined as transcorneal pressure difference. Neonate, infant, toddler and children, the normal IOP is between 10 to 20 mm mercury, similar to adult. It exists between a balance of aqueous humor production from the ciliary body and is drainage via the trabecular meshwork. Ocular hypertension occurs when the IOP raise more than 20 mm mercury. It is usually regulated by the volume of the aqueous at the anterior chamber. However, this process takes about 15 to 30 minutes to occur. Ocular hypertension can be caused by excessive production, inadequate drainage, medication and trauma. However, ocular hypertension is not equal to glaucoma. It would be natural to assume that in a normal intraocular pressure, there will be no glaucoma. And if the intraocular pressure is high, the eye will have glaucoma. But that is not the case because there is a normal tension glaucoma and there is ocular hypertension. Therefore, for all patients with elevated IOP, it is mandatory to look for the glaucomatous eye changes such as loss of visual field, detectable damage on the optic nerve and disc. Otherwise, if the IOP is elevated without a glaucomatous changes, then the diagnosis is only ocular hypertension. Glaucoma is not uncommon in children. There are primary and secondary glaucoma. The secondary can be caused by ocular or systemic disease. This table shows a metabolic disease and syndrome with its common ophthalmic condition, which cause this kid to come to us for anesthesia. They either come because of the glaucoma itself, or they come back later after a cataract surgery, which predispose them to developing the secondary glaucoma. These are the list of anatomy and pathological features that influence the intraocular pressure. can be divided into intraglobal and extraglobal. As far as anesthesia is concerned, face mask application and prone positioning will cause increase in IOP. A study was conducted in China which involved more than 6,000 children 4 to 18 years old, at which they were looking into physiological features which influence the IOP. Age does not significantly affect IOP. However, children has an M-shaped phenomena where the IOP peak twice at 8 years old and 16 years old. And unfortunately, girls have a higher IOP than the boys, and greater body weight, BMI and body height also contribute to higher IOP. These are the list of tonometer with the different principles commonly used to measure IOP. However, the gold standard is a Goldman applanation tonometer. Look at this complex equipment. Is this a tonometer? No, this is a slit lamp. Goldman tonometer is this one with the eyepiece where the eye prism is in contact with the eye to measure the IOP. Tonopen and eye care rebound tonometer is does not require slit lamp. Therefore, it is portable, handheld and battery operated, so it is easy and children friendly. These are the two that commonly seen in the operating theatre. One of the advances in the IOP measurement is this triggerfish, where a sensor is applied in the contact lens-like device to allow continuous IOP measurement. Therefore, it can detect any acutely raised in IOP, especially when it occurs at night. IOP and the anesthesiologists. These are the 5 scenarios where IOP is important to us. First, when the patient with acutely or chronically raised IOP come for corrective eye surgery. 2 is a patient with chronically raised IOP come for non-ophthalmic surgery. 3, a normal patient with previously normal eye come with penetrating eye injury. The last 2 is the anesthetic drug which affect the IOP, or the drug used to regulate IOP which affect the anesthesia. Coming back to the poll 3 question, a 3-year-old boy presented with sign and symptom of raised IOP, scheduled for EUA and IOP measurement. How will you anesthetize this child? When it comes to procedure with require IOP measurement, a monitor sedation with ketamine and oxygen delivered via face mask is relatively a common choice. It is also technically easier to insert a supraglottic airway device if a longer procedure is anticipated. Regardless the technique being used, a consistent approach should be ensured, because if a serial measurement is to be made in the future, it can help to reduce a measurement error. This table summarizes the common anesthetic agent and its effects on the IOP. Both intravenous and volatile anesthetic agent cause reduction of IOP 20 to 30%. Ketamine with higher dose more than 5 mg per kilo will have increase in the IOP. What about dexmedetomidine? Dexmedetomidine reduce IOP at the same rate of propofol and thiopentone. Therefore, in an uncooperative child coming for measurement of IOP and pre-medication is necessary, instead of intranasal dexmedetomidine, I guess oral mida and ketamine will be a better option. Majority of my patients prefer GA ketamine for IOP measurement because they would rather have a falsely high IOP rather than falsely low to avoid delay in initiating treatment for glaucoma. Now we know that general anesthesia and the anesthetic agent cause significant reduction in IOP, but which one is better to be used? So this study is conducted in 100 children coming for non-glaucoma surgery, where they were divided into 4 groups depending on the type of anesthetic agent used during maintenance and induction. The hemodynamic parameters and IOP were measured in 4 different times. before induction, immediate after induction, during the surgery, as well as after extubation. Regardless of the induction agent used, whether servo or propofol, IOP reduced significantly immediate after induction, and regardless the maintenance, whether it's sevoflurane or propofol, all four groups show significant raise in IOP after extubation. Continuing with the scenario, after the IOP measurement, the surgeon informed that the procedure is expected to be prolonged, so they requested a consultation. Ventilation in the 60 children. IOP was measured at 4 intervals: before induction, after airway manipulation, and 2 minutes later. So the orange is the ATT group and the blue is the LMA. As you can see here, the heart rate, blood pressure and IOP was elevated significantly after the airway manipulation in ATT group, and the elevation sustained until 2 minutes later. The ATT group also has a higher post-extubation complication in comparison to the LMA. Therefore, in general, supraglottic airway device is superior than the trachea tube because it does not require direct laryngoscope for insertion, and it is less traumatic, hence less complication after removal. First or the second generation supraglottic airway device, which one is better? So this study compared 4 different supraglottic airway in children coming for non-glaucoma surgery. They study between classic, iGel, Prosil and Cobra supraglottic airway, and there is no significant difference in terms of the characteristic of supraglottic airway insertion, the intraocular pressure level and the hemodynamic parameters. Since IOP measurement is routinely done prior to airway instrumentation, I would like to emphasize on the face mask application during back mask ventilation. Be extra careful with placement of the mask, choose a correct size, avoid compression to the eye. Practice good head positioning and avoid flexion and kinking of the jugular venous drainage, which can indirectly cause increased IOP. And during intubation and neck manipulation, be careful while opening the mouth with finger technique, because if you're doing this in adult, usually the thumb will be placed at the zygomatic arch. However, because of the memory, muscle memory, in children, the thumb will always end up on the patient eye, which can cause significant raise in IOP and also trigger bradycardia. It would be beautiful if we can just open the mouth simply by simple head extension. Second scenario is a 10-year-old boy sustained penetrating injury while accidentally press a nail gun and shoot the nail through his left eye. His GCS is 15/15 and CT brain show the nail lodged at the base of the skull. He was scheduled for emergency craniotomy and removal of the nail and examination of the eye under anesthesia. So how will you anesthetize this child? Just now, for a glaucoma patient, we want to prevent a falsely low IOP reading. However, in this penetrating eye injury, we must try our best to reduce the IOP during all of the anesthetic steps. These are the list of the anesthetic procedure which usually will cause increased IOP. We are aware that succinylmetonium for rapid sequence induction will cause significant raise in IOP. So when rapid sequence induction is necessary, to substitute the succinylmetonium with rapid intubation dose of rocuronium. For the rest of the procedure, I encourage that we take care of the depth of anesthesia to prevent sympathetic stimulation and increase IOP. Lastly, the drug used to reduce IOP and facilitate eye surgery, which may precipitate peri-anesthesia complication. This is very important. There are a variety of the medication used by the eye team that may have important anesthetic ramification. Although the effect is favorable for them, it is undesirable to us. This topical agent will be applied into the eye. The excess of the ocular application will invariably enter the lacrimal system and absorbed by the nasopharyngeal mucosa, where their effect will be enhanced because it bypasses the first pass metabolism. So, this common topical agent and their scary side effect to us, the one that we're scared is, hypertension and tachycardia is common with the pediatric agent, particularly the phenylephrine. And this persistent tachycardia and hypertension may be mistakenly thought as a pain and will result in overutilization of opioid and cause delay in awakening and respiratory depression. Bronchospasm is common following miotic agent such as acetylcholine, as well as a beta blocker for glaucoma patient. Therefore, it is important to communicate with the surgeon if you have an asthmatic child or a recovering child from respiratory tract infection, as these kids are having a hypersensitive airway. Bradycardia and hypotension also common after glaucoma agent. To reduce this systemic effect, a digital pressure over the lacrimal duct after instillation has been recommended, and for us, a calculated dose of atropine must be readily available to handle the bradycardia crisis gracefully. Coming to the operating field, usually the head is south-facing during the eye surgery to provide an unrestricted access of the eye to the surgeon. Surgeon usually will be operating from the patient head and the microscope on top. Therefore, it is mandatory that the breathing circuit and airway adjunct does not encroach the surgical field so that the microscope can move freely. A group of anesthetists has studied the suitability and ergonomicity of supraglottic airway device for eye surgery. Which one is surgeon friendly? Basically, they insert all type of airway device that they are used in their center and anchor it to the chin, connect to the breathing circuit. So from there, they assess the stability and they measure the vertical projection from the chin upward and how this device and the anchoring technique may encroach the surgical field. Out of 12 devices, securing the airway device to the chin best achieved with classic and Embu ASPA-FLEX LMA, and the desirable vertical projection less than 5 cm were favorable with classic ASPA-FLEX and also a Prosil LMA. Sometimes, even the preformed oral ray tracheotube give rise to a high vertical projection, making the positioning of the microscope suboptimal and affecting the surgical skill. And the most important point in the operating field is a quiet eye. Ideally, the surgeon require the eye to be center, motionless, especially during intraocular surgery, and this can be achieved by a muscle relaxant. To those spontaneously breathing kids, we need to keep the depth of anesthesia adequate, because ocular stimulation at the insufficient depth of anesthesia can result in Bell's phenomena. So what is the best stage of anesthesia? Textbook speaking, stage 3, plane T is considered the best surgical plane. So looking at this girdle stage of anesthesia, from stage 2, the muscular activity and the eye movement increase. And from stage 3, from plane 1 to plane 2, the eyeball activity abates and the eye assume in neutral position. However, ocular stimulation can still cause upward deviation of the eyeball, which is also known as Bell's phenomenon. Therefore, we have to maintain the patient in a deeper plane, stage 3, plane 3, where the eye is center, the pupil is dilated, and eye reflexes are abolished. Hence, I would like to introduce to you McBell. McBell is a minimum alveolar concentration at which inhibit the Bell's phenomenon. So what is Bell's phenomenon? It's upward eyeball rotation upon eye stimulation. So this study conducted in 43 children aged 1 month to 10 years scheduled for EUA of the eye using an up and down method of sevoflurane concentration depending on the response. So MAC-Bell was determined by the average of MAC at the midpoint of 14 crossover pair, and MAC-Bell for sevoflurane in children is 1.8. So why MAC-Bell is important? Because Bell's phenomenon may compromise the surgery. Traction or stay suture may be used by the surgeon to bring the deviated eyeball to the center position, but this may injure the eye. Or the anesthetist may be requested to administer muscle relaxant, although in most cases deepening the anesthesia is enough, but at the cost of increased procedural time. So it is very important to understand the depth of anesthesia and offering the surgeon the best surgical plan. I hope this discussion is beneficial to everyone, and thank you for staying with us.
Okay, thank you for your interesting lecture. And I'd like to give big applause to all three speakers. Now, this is a Q&A session, and Dr. Teddy will moderate this session. Dr. Teddy, please.
Thank you very much, Dr. Hiso, and I would like to congratulate all our speakers this afternoon for that very informative lectures that we had. Okay, so we have a couple of questions in our chat group and a Q&A box, and I believe some of our speakers already answered quite a number of them. So what I will do is just to highlight some and discuss some that is quite controversial and raise a lot of questions. The first thing is the combination of our pre-medication. I think one of that is a combination of Presidex, ketamine, or Presidex or dexmedetomidine plus midazolam. And I think Dr. Hafizo just mentioned just now about her more preferred combination, which is midazolam plus ketamine or something else. So I will start first with Professor Ji-Yoon regarding your point or your I know you answered this already in the Q&A box, but just to highlight some key points regarding your preferred combination for pre-medication. Do you prefer dexmedetomidine plus midazolam? And I saw that you use dexmedetomidine plus ketamine, but mainly that is for your radiology case. So please, can you enlighten us more with regards to the combination of choice for your end? Yeah.
Yes, based on my experience, I usually prefer to use midazolam or small dose of propofol when the patient has the peripheral intravenous line catheter. But when the patient has no intravenous line, the second choice for me is actually the use of inhalation anesthetics with face mask. And VMA, I also prefer, but many patients show the fear for something in their face. So actually, so for that case, I've tried to use intranasal dexmedetomidine with ketamine. The dose is dexmedetomidine is 2 micrograms per kilogram and ketamine is 3 milligrams per kilogram with combination. But after the give of intranasal dex and ketamine, I have to wait about 20 minutes. Yeah, so actually for general anesthesia, I think it is easy to control when I use the inhalation anesthetics for the pre-medication.
I see. Thank you very much for that. So it's a Presidex plus ketamine combination for you as well as pre-medication. How about you, Professor Yao? Professor Yao, from your end, what's your usual combination for pre-medication?
No.
Oh, okay. How about you, Dr. Hafizo? Yes, can you share with us your preferred pre-medication? If, let's say, going back to the case that you have given patients with glaucoma or increased intraocular pressure?
I think the key point here is for the patient coming for eye surgery or usually the glaucoma, usually they want we want the familiar technique. So we usually, my previous center, we use gas inhalation induction and ketamine. After we manage to get the IV access, and then we let the surgeon to do their measurement before we go for the advanced airway management. Because here in Malaysia, pre-medication with dexmedetomidine is not really not regularly practiced, and not all eye patient with come for eye surgery come to the pediatric anesthetist. So we want them to practice whichever technique that they are familiar and comfortable, and to ensure the patient safety.
All right, thank you very much for that answer. I think there's another question and some debate going on in the Q&A regarding the use of supraglottic device for young patients. How young do you usually use it? And then the next question to that, if you are removing the LMA, so what depth of anesthesia do you usually go for? I mean, do you remove the LMA awake or do you remove it deep? So let's answer first the first question. Maybe I will ask Dr. Yao, for, let's say, for example, patient coming in for a premature patient coming in for examination under anesthesia, will you use a supraglottic device or will you immediately intubate this patient if it's coming in for general anesthesia?
There is a repeating suggestion.
Okay, I'll repeat the question. So if, let's say, patient is coming in for a examination of anesthesia and they are premature and they are low birth weight, right? And what will you use LMA for this group of patient, or will you prefer to just intubate the patient from the start?
Can I read the spec list in Chinese?
Okay. Noted on that. And how about you, Professor Ji-Yoon? If, let's say, if you're given the same, almost the same case of premature patient, will you intubate the child, or you will just you even consider using LMA?
I think it depends on the gestational age and the time after birth. When
you have
the
certain magic number or like age group that you have a
so
you can actually share with our residents or our fellows who are viewing.
Actually, when the patient's gestation age is very low and the time after birth is also very short, I prefer the endotracheal intubation, especially when the patient has lung disease such as bronchopulmonary dysplasia, because it is easy for me to control the airway when the airway event occurs. Yeah, it is easy to control, use endotracheal tube, but when the patient has no lung disease and maybe the infants with the age is older than 5 or 6 months, I will use the supraglottic airway device.
Okay. Yeah, okay, noted on that. How, Dr. Hafizo, I mean, if you are removing LMA, let's say for infants or young patient, do you usually reverse them, or do you usually remove them awake or deep?
When I'm using a supraglottic airway device, even if I paralyze the kids, usually I reverse them in deep, and then I will extubate them in deep extubation. because I can control the situation, and then the surgeon will be very happy looking at the patient very calm and position in recovery position, and they wake up calmer in recovery.
All right, noted on that. Professor Yao, anything to add on? I think Professor Yao mentioned earlier on in the chat group that for premature patients and young patients, they usually monitor them 24 hours after GA, meaning that they, even if it's just a short procedure, if they are premature, they will admit the patient and monitor them for 24 hours. Professor Yao, anything to add on to that? Then if none, I will move on to our next question. So I think one of the interesting thing that Dr. Hafizo has mentioned earlier on is about the MAC bell, which is actually quite new. Also for me, that the 1.8 MAC is actually quite interesting. I'm just wondering whether, is this 1.8 MAC is actually relevant, I mean, applicable to all age group, or do we need to adjust the MAC bell on certain age level? Like for example, if we have a teenager who have higher requirements or 3 months old compared to, let's say, a 2 months or a 1 month old. So do we need to adjust the MAC bell, or the 1.8 MAC is the magic number that we should all maintain in order to ensure that there'll be no movement of the eye during examination, anesthesia, or any eye surgery?
So from my short reading, because MAC bell is also new for me, there's another study done in a premature infant coming for eye surgery. So for this premature neonate, meaning that less than 44 weeks of gestation, the MAC bell for them is, for sevoflurane, is 1, and the bigger children is 1.8.
Oh, I see. So those are the ranges that we can actually play with our sevoflurane. Thank you very much for highlighting that. I think there's a lot of question regarding ketamine in our Q&A box, and I think we need some time to discuss thoroughly on that. I understand that from Dr. Hafizo's lecture, that the one that she shared is that if you are not going to give ketamine at more than 5 milligram per kg per dose, then you will not have that increase in intraocular pressure. But the question that we have in here is about nystagmus. In your experience, right, if you give ketamine as pre-medication or a part of your, let's say, EUA or any eye surgery, do you actually experience certain nystagmus during your surgery that your surgeons will complain? Professor Jiun?
Actually, when the eye surgery, I usually give the rocuronium, the small dose of rocuronium. So there's no surgeon complain about the nystagmus.
Yeah, because it's already paralyzed and all that. So it blunts but then Professor Dr. Hafizo, so from your end, do you actually have any case or experience wherein you give ketamine as pre-medication and then you didn't paralyze and there's some issues of nystagmus, or you don't actually use ketamine at all as pre-medication for eye surgery?
We rarely get the chance to pre-medicate our children, but when we give the intentional induction, and before we let the surgeon do their procedure, we give IV ketamine 1 to 2 milligram per kilo. Usually that nystagmus was never an issue to them.
Okay, so if it's given as 1 to 2 milligrams. All right, noted on that. Professor Yao, from your end, any ketamine experience for eye surgery? May that be in premature patient? All right, okay. Yes, Professor Yao, you unmuted, yeah.
No better suggestion.
Okay. All right, noted on that, Professor Yao. Okay, there's a last question here. I think this will be our last question for this session. In a premature patient for retinopathy or prematurity procedure that is about past 60 weeks, usually in textbook you'll say 50 weeks is the corrected age, then would it be safe to do an outpatient ambulatory center, which is not part of the hospital? So if your patient, even if they are premature, in your center, based on your protocol, will you allow a premature patient who are already older than 60 weeks to be done as under day surgery or outpatient? If let's say they're coming only for minor procedures, EUA, examination of under anesthesia and all those things. Let's start with Dr. Hafizo.
In my center, our local guideline is to allow case for day surgery when the corrected age is more than 6 months.
6
So
months.
we don't do.
Okay. How about you, Professor Jiun?
Yeah, similar in our center. Actually, for the full-term baby, the corrected age over than 60 weeks, the surgery can be done by the day surgery can be done, I think. But in premature patient, we recommend the 24 hours monitoring of saturation after surgery in infants younger than 5 or 6 months.
All right. Okay. I think thank you very much, everyone, for that very interesting lecture, and of course for providing us very informative answers to sum up everything for this evening's webinar. I hand over back the session back to Professor Hiso to close the session and for some announcements. Thank you.
Okay, thank you for fluent management of the Q&A session. Okay, we almost there, and we will have some ads. Kathleen, please share the slides. Okay, the Q&A, the certificates of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. Post-webinar survey will be forwarded tomorrow, April 18th at 5 p.m. in Singapore time through email. And please ensure that you have correctly keyed in your full name and email. And yes, once again, this video will be reviewed, posted in ASPA web homepage and Facebook and YouTube. And please visit these sites, please. And there are some, okay, finally, we will have ASPA 2022 in Istanbul. And please come and visit this homepage, and please save your date, and see you at Istanbul. And okay, there will be a 5th ASPA FLEX2 webinar in May, and please don't forget to join this webinar. And it's time to wrap up this webinar. Thank you all 3 speakers, and Teddy, and especially Catherine for your IT support, and all the audience. Thank you, audience, for sharing your time, and stay safe and have a nice weekend again. Okay, thank you. Bye.
Thank you. Bye.
Thank you, everything. Thank you, President. Thank you very much.